And I'm going to be talking about the effect of double layer sign and its dimensions on conversion to eMNV or over the 3-year follow-up that we had for this patient group. So these are my financial disclosures, and we will ask all of you to show that during your presentation. So it's been suggested that the double layer sign which is a shallow separation of the retinal pigment epithelium from the Bruch's membrane, as seen on optical coherence tomography, represents non-exudative macroneovascularization. And OCTA has given us a lot more understanding, but we don't have OCTA as necessarily in every trial. So we're going to have to be able to use our existing OCT imaging to be able to find those patients who are at high risk for conversion. So what we have done is we revised the grading and we regraded for DLS for all OCT scans from the EDNA repository, and this primary grading modality was as the OCT and captured on the macular scans. So graders reviewed all the B scans for the relevant patients, and if DLS was present, then they measured the length and the height, the separation, and they have worked very hard on this. So this is just to show you as to what's happening on the A panel A. There is no irregular elevation, and then as you go to the right, you will see that there is DLS-like, and then measuring the height and the length of it. So it was a very detailed grading. So originally we had 548 participants. We had to exclude a few because of different reasons, ungradable or unavailable OCTs, or some patients didn't make it to the final visit. So of those who we included, a subset had irregular elevation, and some of those, as you can see, the 167 had DLS absent, and those who had on the left-hand side, the 38% had DLS present. So the baseline cohort characteristics are not different to pretty much any AMD cohorts that you see. They are more elderly, there are more females, there are ex and never smokers, which is getting more and more common that we have more never smokers in our studies. And the OCT features of intermediate AMD are on the right-hand side. So they were also, as I said, they were more females. They had more drusens and intraretinal hyperreflective foci, and also hypertransmission in those who had DLS. Those who converted to eMNV, they had more DLS-like creatures in their OCT, and they had the types of different eMNV, as you can see it on the slide. So DLS was helpful for us to be able to find who was going to convert at 18 and 36 months. And you can see it on the Kaplan-Meier curve that it really nicely separates quite early on. And by about 36 months, there is definite difference between those who did and those who did not have DLS. So DLS was also very helpful in establishing the hazard ratios, and having DLS gives you a very high hazard ratio. So it's a sign that we can competently and repeatedly and reliably grade for, and that's why it's a good sign for us to be able to look for on our patients. And the maximum length and the maximum height, as you can see, they were not very different between the two groups, and we didn't find that extremely helpful in further defining our groups in those who were converting or who weren't. But so if you have a look at this, the family history and some of those other characteristics are more helpful. So although we have put immense amount of time and effort into measuring, the good news is that looking at very competently at the images and making sure that you have graded DLS very well is more helpful than going into grading, and which in a busy clinic would not really be feasible anyway. So overall, our results confirm that DLS is a risk factor for progression to exudation. It really is questionable if you do really need to measure it, but we do know that the presence of it will give you a higher risk for progression. So in a busy clinic, you can establish it, and you will be able to look at that. And the presence of DLS, as I said, elevates the progression more than twofold. So you really have to know, if you grade for it, then these are the patients that you might wish to follow more carefully, and monitor those patients more carefully with high resolution imaging and OCTA. But as I said, we haven't graded OCTAs in this study, so therefore I can't tell you just as yet. We are going into that as well, and we'll be able to present it next time, hopefully. Thank you very much.
Thank you very much. Unfortunately, we're on a very tight schedule, so every speaker has 6 minutes. How you use it is up to you. If there's no time for discussion, unfortunately, we have to move on. Please do not take